And now I will introduce Benjamin Kematick, which is a doctor in pharmacy from the University of Buffalo. I will do a very quick introduction because I want him to speak, but you can be assured that his current position in outpatient palliative care pharmacist at Dana-Farber and Cancer Institute, with a lot of very interesting research of interest, makes him a very good speaker for the depression and end-of-life management of suffering. Thank you.
Thank you so much for inviting me. You'll notice that there is a link there right at the beginning. I'm just going to take a little survey. I bet you no one was expecting a quiz, but there'll be a little quiz because I like to know who's here and who I'm talking to. My name is Ben. I'm a pharmacist with Dana-Farber Cancer Institute. I primarily work in the outpatient palliative care clinic with our team. I don't have any actual or potential conflicts of interest, but like Dr. Ely, we will have some overlap and we'll be talking about the use of medications off-label. At the end of this presentation, I'm hopeful that you'll be able to specifically articulate some of the challenges with treating depression at the end of life with a limited prognosis. And we can talk a little bit about how we can integrate screening and diagnosis in order to identify the best patients to perhaps choose antidepressants or other therapies for at the end of life. We'll also talk about the limitations, similar to Dr. Ely, of most of our medications that we have available to us, some of the clinical pearls, and the limitations of our conventional antidepressant classes. We'll also identify emerging therapies at the end and lines of research for the treatment of depression in the future, because things are going to change, and hopefully soon. I don't know if I did the CanMed's competency framework right, being American, but I think it's Scholar, so integrating the best available evidence into practice. If I'm wrong, you can skewer me at the end. So first, if you go to pollev.com/Benjamin Kima 686, you should be able to answer where you're from. I don't have a sense, oh, there we go. So looks like at least we'll be able to see the end results. It's kind of working. So, mostly Canadian. My apologies. Everything that everything that I talk about labeled on label is from a U.S. perspective. So, I apologize. If I'm wrong, you can correct me at the end. I'm totally happy with that. So, we'll move on. Maybe. There we go. What's your profession? Who am I talking to? It can be helpful for me to do that. So it looks like we've got at least one pharmacist. All right, good. So my apologies to some of our physician colleagues. I tried to make the slides a little bit less data heavy. I know that we all love our data, but I'm hoping to talk to you a little bit more about who we are and what we do. So obviously, we have a diverse crowd, but mostly physicians here, so that's helpful. And then, in what setting are you currently practicing in? That's going to significantly impact the choice of medication that we have, so depending on prognosis. So for me, when I work in outpatient palliative care, if I see patients with weeks to months to live, I might make different decisions about medications than you would on your inpatient palliative care units or with hospice. So it looks like inpatient palliative care is running away, but maybe not, I can't tell how much. So most of you are inpatient palliative care physicians from Canada. We'll make that generalization. So what I want to talk about is, why is this important? This is a significant portion of our populations. So I work primarily in cancer. 15 to 30% of patients with cancer suffer from depression, and it's a major quality of life issue. Not only that, as we continue to survey and survey the population, the rate may be increasing year over year. And the incidence can be different from different cancer types. Liver, lung, pancreas can have a higher incidence of depression versus other cancer types, and as well as other serious illnesses. And it's not just depression or anxiety. It can be adjustment disorders. It can be grief. It can be existential distress, other depressive symptoms. But not every symptom that occurs is appropriately treated with a medication, right? Some of it has to be treated with our presence. And it gets worse as our patients advance in their disease. The psychosocial symptoms get worse. So 60% of palliative care patients versus 25% of cancer outpatients. And that worsening of symptoms is not just anxiety and depression. I think this is really difficult for me as a pharmacist to sit with because, for one, it's not just a somatic symptom, it's a psychosocial symptom. I feel very confident in when patients have pain crises being able to bring them in and treat them very quickly on the scale of hours. But as we discussed with Dr. Ely, there's serious limitations with the medications that we have available to us right now. A survey of UK palliative care physicians found that 2/3 of palliative care physicians don't feel comfortable diagnosing depression, and 50% of them don't have access to a psychiatrist or a consult psychiatry liaison. So it can be difficult for our teams to manage depression by themselves. And then we also have to do a good job of distinguishing depression from grief, the normal dying process, and then balancing the limited prognosis with time to effect. And screening for depression in our patients is harder. The somatic symptoms like weight loss and fatigue may not be indicative of depression in palliative care like it is for a normal, healthier population. So that forces us to rely on psychological or cognitive symptoms of depression, and also distinguishing grief from depression and existential distress from depression. Grief is accompanied by hope, a response to support, lack of active desire for an early death, or anhedonia. These patients are going through a normal and healthy process, and grief is not something that we want to try and treat with medication. That's what we're here for as palliative care clinicians. Depression is the maladaptive response to the situation where they are losing hope. They may have anhedonia, and they may feel for feelings of worthlessness. So it's distinguishing depression and depressive symptoms from normal and healthy dying process, including existential distress, so feelings of loss of identity, loss of independence, other sorts of unfulfilled obligations. Existential distress, we could potentially treat with our medications, but we're not going to do it effectively. So identifying the patients that are most appropriate for medication or non-medication interventions will be of utmost importance. So how can we do it? So, not a physician. I don't do any diagnosis, but what I do find helpful is the PHQ-2. It's 2 simple questions. It doesn't even feel overwhelming when you put it on a slide. Asking the 2 simple questions, are you feeling down, depressed, or hopeless most of the time over the last 2 weeks? Plus or minus, have you found that little brings you pleasure or joy over the last 2 weeks, can be really helpful in moving along your busy clinic day or your interview. Because if the answer to those questions is no, that has a negative predictive value of 98%. However, if the answer to one of those 2 questions is yes, then it's reasonable to follow with a PHQ-9, which can help you stratify the severity of depression and how appropriate a patient may or may not be to treat. There's also the hospital anxiety and depression scale that you can use similarly for screening. But I don't pretend to make any diagnoses. They should be made by my physician colleagues, and it should be made separately from the screening criteria based on the DSM and other objective criteria. So once you've identified a patient with depression and you think that they are deserving of an intervention that would respond well to treatment, what do we have to do? So the first thing is determine our prognosis. So as I mentioned, for patients who are expected to live for a longer time, we may be able to use our more conventional antidepressants or other sorts of non-pharmacological interventions. But if we're not able to give medication enough time to take effect, we want to choose something else that may be helpful. And then, like Dr. Ely said, identify other comorbid conditions. Depression often walks hand in hand with other symptoms, especially in our patients with palliative care. And so choosing medications that give us a 2-for-1 effect, or sometimes a 3-for-1 effect, is really important. And then once we've got a good sense of who the patient is, we want to choose our appropriate therapies. And again, the reason it's important is because many of our interventions take time to show efficacy, and we have to choose the one that's most appropriate for the patients. And if it's a psychologic intervention, they have to be able to engage with it and be willing to engage with it. I found this article by Drs. Agni and Barrera really helpful. I stole it because it's really good. And it goes through the variety of non-pharmacologic interventions that may be available to our patients, and goes through the data in our patients at the end of life as they're dying. And I think it's really helpful to see some of the limitations of our conventional psychotherapies as well. So cognitive behavioral therapy, which focuses on changing thought patterns and processes, can take a number of sessions, 5 to 20 sessions, and that can take place over a series of months. But it's really effective, right? So if we're able to have patients go through that, spare them from drug interactions or side effects, we should be thinking about that. There's also focused interventions for our patients, and specifically more towards the end of life. So dignity therapy, which were 2 sessions designed to reinforce a dying patient's sense of worth. The feasibility study found significant improvements, but so far randomized controlled trials found no difference on depression, but an improvement in quality of life. So it still might be a worthwhile intervention. Supportive expressive therapy, especially for patients who are having existential distress, may be helpful. Unstructured group therapy, which can take place over a period of weeks, may be helpful, but they have to be willing to engage and share with others what's going on and what they're struggling with. But it has been shown to be effective in improving quality of life and psychosocial issues. And then more towards the end of life, short-term life review in hospice, 1 to 2 week interventions focused on spiritual well-being. They can be effective in improving depression as well as anxiety, suffering, and happiness. So as the shortest psychotherapeutic intervention, that might be something to consider for patients with limited prognosis. I think you should talk to your social work colleagues and your psychologist colleagues about what's the most appropriate. Certainly don't talk to your pharmacist about about these. But as a pharmacist, my favorite thing is when I don't recommend a medication, because there's something else that saves us, right? And so what are the comorbid conditions that we see in our patients? So obviously pain. We know from chronic pain patients that there is a huge overlay of depression and pain. And so step 1 for treating many of our patients is treating the pain and getting it under better control. Because when you're in pain all day, you can feel worthless and you can feel down. And so that, for me, is often what I'm called to do. And at the same time, if the pain is relatively well controlled and there's still room to improve and the mood is different, we can choose an appropriate medication that does both treat the depression and the pain. And then and then insomnia and fatigue are also huge portions of what goes on with patients with depression, especially towards the end of life. So choosing medications that can perhaps brighten up people or help them sleep and get back on a regular sleep-wake cycle is paramount importance. And then lastly, appetite. As Dr. Ely mentioned, I think appetite can also be not just the language that gets used in cancer, get stronger to fight, but also the act of being with your family and the cultural importance of being able to at least have a few bites of a meal. It can't really be understated. So if a patient is struggling with nausea and appetite, choosing a medication that may be helpful for that is important. And so what do we have available? We already talked about most of them. Really, on label, we have only a few classes of medications: SSRIs, SNRIs, TCAs, and then the other unique antidepressants. But off label, there's the stimulants and ketamine and antipsychotics. So we'll talk about stimulants and ketamine today. But that is just to say we don't have all that many tools. There's differences between each individual medication, but every single medication here listed has its limits. So the first class to talk about is SSRIs. Like Dr. Ely talked about, you have to start low and go slow most of the time. The titration schedule is such that you need to start a medication with no promise of any benefit and maybe a promise of side effects, and tell them to take it every day for 3 weeks and then come back and see me, and then we'll see where to go from here. I think it's really, it can't be said enough, the burden of taking a pill every day, an additional pill every day that our patients get asked to do. They often have very, very long med lists. The example I like to give of how hard it is to take a medication. So a survey of patients prescribed a statin for primary prevention. Initial fill of that medication, so even picking it up from the pharmacy, is as low as 50%. Initial adherence to that medication is 25%. So 1 out of every 4 people who has high cholesterol and is prescribed a statin, this is going to save your life, and you have to take it every day for 10 years. Initial adherence was as low as 25%. After an acute coronary event, that number goes up to 40%. So people don't like taking medications every day. It's really hard. And so especially medications that don't necessarily show a benefit right away. I think it's a little bit easier to convince someone to take an opioid when they can immediately see the effect of that medication. But for SSRIs and SNRIs and TCAs, it can be really difficult. Dr. Ely did a really good job of talking about the side effects and QTC prolongation. And, I'm a pharmacist. I love asking people to start methadone. So it's like my favorite drug. And so keeping in mind that additional insults to the cardiac conduction is important. And then I think perhaps an understated side effect that often happens with SSRIs and SNRIs is the sexual dysfunction. So for patients who are still healthy and are still able to be intimate with their partners, a decrease in libido that we often see with SSRIs can be a huge quality of life impact, and maybe that's the side effect that's completely intolerable to them. And then depending on the SSRI you pick, some can be more activating like fluoxetine, and others can be more sedating like paroxetine, like Dr. Ely said, and she did a really good job of showing those drug interactions. And then lastly, just to talk about administration at the end of life. So with SSRI withdrawal or discontinuation syndrome, that's a feeling of dysphoria and feeling terrible. And if we are expecting our patients to lose the ability to swallow in a short period of time, is it worth starting a medication that we can no longer give in a few weeks and that will end up making them feel worse as they withdraw off of it? And so a selective a choice of these. So just the clinical pearls, I think Dr. Ely already did a really good job of showing how sertraline, citalopram, and escitalopram, not activating nor sedating. Drug interactions are a little bit better, but they are still mild 2D6 inhibitors, and they can prolong the QTC. Paroxetine, on the other hand, doesn't seem to have QTC prolongation, but it has a number of drug interactions which can then make the QTC worse, so it depends on your patient. Ask your pharmacist. And then lastly, fluoxetine can be activating, so maybe making anxiety worse. Also a potent 2D6 inhibitor, can prolong the QTC. So especially for paroxetine versus fluoxetine, if you have a patient who doesn't do a good job of taking their medicines every day, you absolutely don't want to recommend paroxetine because you might end up having the withdrawal syndrome even if they haven't lost the ability to swallow. Next class of medications are the SNRIs. So here, because of the norepinephrine reuptake inhibition, we do see a dual benefit for pain. I prescribe duloxetine all the time for chemotherapy-induced peripheral neuropathy. It is one of the first things I think of. I prescribe it way more for chemotherapy-induced peripheral neuropathy than I do for depression, but it's also the only thing that NCCN says has any evidence now, right? So we're kind of limited with that. But because SNRIs are good for different types of peripheral neuropathy, if a patient still has neuropathy, it could be a good choice. I think importantly to point out with duloxetine is that it doesn't have QT prolongation, and in fact, in the labeling of the medication, it says it might actually shorten the QTC interval, which as a pharmacist, you never see, right? It has CYP2D6 and 1A2 inhibition, so similar to other drug interactions that were presented by Dr. Ely. And then venlafaxine can also be effective for pain management as well as mood improvement. It is less potent of a norepinephrine reuptake inhibitor, but it had some good data on it before duloxetine came out, and then duloxetine came out, and then no one was prescribing venlafaxine anymore, but it's okay. You can still use it. It's still a good drug. And also just to say, they have all the same limitations of SSRIs, the timing, 2 to 3 weeks for effect on mood. But when used for pain, perhaps we can titrate it a little bit more quickly. When we use duloxetine for pain, we might see improvement in as little as a week, which is still a long time, but it's better than waiting 3 weeks to see full effect. And just like Dr. Ely said, start it, reassess after a week, get up to the most appropriate doses. Duloxetine for pain, doses higher than 60 milligrams per day have not been shown to be more effective, but may add more side effects. But for managing depression, you can go as high as 120 milligrams per day. Tricyclic antidepressants, I'm glad that people are taking photos of them because that's my cat and my dog. And the reason I put them up there is because when you give them to people, since they're so anticholinergic, they will put people to sleep, like a 16-year-old cat in a sunspot on a bed next to his brother. But the beneficial dual actions for tricyclics are for pain and insomnia. The main issue I have with using a tricyclic as an antidepressant is that in order to get to an effective dose, you are going to cause blurred vision, headache, confusion, tiredness, all of the anticholinergic side effects, which sometimes get better with time, but are often precluding us from being able to use them. So like SNRIs have more receptor interactions than SSRIs, TCAs have even more. And so they also lead us to more drug interactions and also significantly prolong the QTC. Mirtazapine, sorry. As Dr. Ely mentioned, is very unique. It's not a traditional antidepressant. But we also don't know exactly how it works, and so that makes it exciting for pharmacists because it's got receptor action at histamine receptors as well as serotonin receptors, different outcomes at lower doses versus higher doses. But what's important is that when used for depression, it doesn't matter what dose you give. You can be 15 or 30 milligrams of mirtazapine, improve both weight and depression regardless of the dose. And uniquely compared to some of our SSRIs and SNRIs, it doesn't have any CYP2D6 inhibition. So if you're worried about tamoxifen, this may be a good medication to consider. It can have sedative doses at lower doses, and so sometimes you might be able to get a 3-for. So 3-for-1. So mood, appetite, sedation for a little bit. And uniquely with mirtazapine, if you do see an effect within the first 2 weeks, it can be predictive of further effect. And so you're able to shorten perhaps your time of reassessment. The last traditional antidepressant that we have is bupropion. As Dr. Ely said, it can be activating. So there is some okay data, not good, for use as a medication in cancer-related fatigue. But as an antidepressant, it can be effective as well, perhaps a little bit shorter of a time frame, 1 to 3 weeks. And it can be used as adjuvant because it doesn't have serotonin effects, but it does seem to inhibit dopamine and norepinephrine reuptake. It will absolutely reduce the seizure threshold, so do not use in patients with brain mets, and it reduces the desire to smoke. But specifically for depression in palliative care patients, there's like no data. So you're using it as an antidepressant because it's good practice and it's approved, but not anything else. And now we get into the fun stuff, the off-label things. So stimulants, as Dr. Ely mentioned, much quicker time to effect than all approved antidepressants, on the order of hours to days for symptom improvement. But it's difficult to distinguish the antidepressant effect from the improvement in somatic symptoms. So if you're improving someone's fatigue, you may be brightening their mood. But there was a Cochrane review looking at 3 trials totaling 62 participants that demonstrated that oral psychostimulants as monotherapy significantly reduced short-term depressive symptoms, not depression, depressive symptoms, when compared with placebo. And it found that those stimulants were also well tolerated, and well tolerated compared to placebo. So there wasn't additional dropout when using a stimulant versus placebo. But I think one of the interesting things that we've tried to do in palliative care is use psychostimulants as a bridge to further and durable results with SSRIs or traditional antidepressants. And there is some data for it. There is one clinical trial combining methylphenidate and citalopram, looking at 12 patients that saw a quicker time to effect as well as sustained effect when combining methylphenidate with citalopram. But then when combining methylphenidate with sertraline, we don't see it. So, you know, it could be a bridge, but if you only have days to weeks, you don't have time to sit around, wait and titrate an SSRI or an SNRI, a stimulant can be helpful, especially if a patient wants to be awake and able to engage with their family, which can be its own improvement in quality of life. And so we also want to have caution in cardiac arrhythmias and hyperactive delirium. It can make it worse. Most of the data is for methylphenidate. There is one trial with dextroamphetamine. For modafinil in the palliative care population, there's like one trial, and it wasn't super positive for depressive effects, but you know, your mileage may vary depending on the patient's ability to tolerate. And lastly, we get into ketamine. Ketamine I'm using a lot more for pain, but not necessarily for depression. And just to review, ketamine is a dissociative anesthetic commonly used for surgical procedures. But when we're talking about it in palliative care, we're talking about sub-anesthetic doses. What's really unique about ketamine is that the way you give it matters. When you give it via the oral route, it's extensively metabolized by first pass, and you get a lot of norketamine. So if you're looking for ketamine effect, you may not be getting it if you give it from the oral route. And that's important because the trials that we have for ketamine all started for IV infusion. So and these are not in a palliative care population. These are major depressive disorder. But what we saw was that when we're giving ketamine, we see a rapid and robust reduction in symptoms as on the order of hours. So 6 hours later and sustained for 3 days, patients given 0.5 milligrams per kilogram of ketamine over 40 minutes showed much better improvement. And there have been multiple trials since then that have further investigated the subanesthetic effect, or the effect of subanesthetic ketamine on depression. So how does ketamine actually work in depression? Well, you go, well, it's an NMDA receptor antagonist. It's how we use it in pain. It helps potentiate opioids. Well, if that were the case, we'd be able to use other NMDA receptor antagonists to help. But ketamine is the only NMDA receptor antagonist to consistently demonstrate this effect. So it's not the NMDA. So how else does ketamine work? Well, it also activates mTOR receptors as well as increase AMPA receptor activation. I think what's interesting, once we got to the approval of S-ketamine, intranasal ketamine spray, we found that naloxone and naltrexone seem to block the antidepressant effects of ketamine. So there may be some endogenous opioid release related to ketamine infusion. And so blocking that is part of how, or blocking that reduces our antidepressant effect. So there may be some in play of the endogenous opioid system at play. And so does it work? So specifically meta-analysis of IV infusion ketamine for depression. There was a systematic review and meta-analysis that totaled 234 participants in 9 trials. Again, these are not palliative care patients. These are patients with major depressive disorder, bipolar depression, and one in both. And these are all patients who have what's called treatment-resistant depression. Most of the time, they have failed traditional antidepressant therapy. The doses were the same as the Berman trial, usually 0.1 to 0.5 milligrams per kilogram per hour over 40 minutes, which is less than 0.1 to 0.5 milligrams per kilogram. And the crossover time range from 7 to 14 days. Together, pulled together, ketamine infusion results in superior reduction of depressive symptoms, starting at 40 to 60 minutes, peaking at 1 day post-treatment, and lasting more than a week, but less than 2 weeks. So we see a very similar result that we got with the initial Berman trial. Rapid and sustained for about a week. What's important to note here, especially as we talk about S-ketamine next, is that all-cause discontinuation between IV ketamine and placebo was not different. Ketamine was found to be acceptable versus placebo. And the only time that there was psychiatric symptoms score significantly higher for ketamine versus placebo was during the infusion or immediately after the infusion. And I bring that up because in March 2019, S-ketamine was approved for treatment-resistant depression. And so the FDA in the US defines treatment-resistant depression as a depressive episode with inadequate response to at least 2 antidepressant trials of adequate doses and duration. So that means you have to have been on SSRIs and titrated them and failed them in order to get involved in S-ketamine. S-ketamine is an intranasal ketamine spray. It's dosed twice a week for 4 weeks, and then eventually it's spread out to weekly and then biweekly. The trials that were submitted to FDA for the approval included 3 short-term efficacy trials and 1 withdrawal placebo-controlled trials. But only one of those trials, Transform 2, met its stated statistical significance for S-ketamine plus an antidepressant versus placebo with an antidepressant. So 1 out of the 4 trials did, but the pooled results favored S-ketamine in its approval, and as a novel medication, it was approved. And so we're great, we have another medication available to us, except we kind of don't. Because in the US, in order to give S-ketamine, it needs to be done on what we call a risk evaluation and mitigation strategy. So the REMS programs, you as a physician and your patient need to enter into and say that you have met the indication for treatment-resistant depression and that this is appropriate. And because ketamine and S-ketamine are drugs with potential of abuse, it can only be given in the clinic. So you have to be able to administer intranasal ketamine in the clinic twice a week for these patients. That significantly reduces access because me and anyone else, we can get IV ketamine in like 5 minutes, but S-ketamine, forget about it, right? What was also noted in the trials was that there was a 7 times risk of dissociation of S-ketamine versus placebo, and it was much less well tolerated than IV racemic ketamine. So for whatever reason, S-ketamine is not as well tolerated as IV ketamine. And as a result, it's difficult for patients to get through the trials, which may be part of the reason why only 1 of the 4 trials met their statistical significance endpoints. And then at the end of the day, what we saw was that over time, the benefit of ketamine begins to prolong. So initially, it's every 3 days, but perhaps afterwards it's 4, then 5, then 6. There's unclear dosing recommendations for S-ketamine and how often you'll need to bring patients back and for how long. It starts biweekly, then weekly, then you can move to every other week. But then from there, there's not really much guidance. And so in a palliative care population, that may not be as important, but we don't know exactly the long-term dosing recommendations. And we poorly understand the endogenous opioid system at interplay with S-ketamine. So what's coming next? In 2016, in our patients, we saw the 2 breakthrough psilocybin-assisted psychotherapy trials come through, showing dramatic and sustained improvement in depression and palliative care. And then there was additionally a MDMA-assisted psychotherapy was shown to reduce anxiety and depression in patients with serious illness. These medications are not available to me and you yet. Well, I say that, but I see Dr. Bosant in the back, so it's available to him sometimes. There is a trial at Dana-Farber and Care Dimensions ongoing. But I bring this up because it's important. These are going to be practice-changing if we're able to get them. They work quickly, and they're not as cumbersome per se as ketamine, which needs to be continually dosed. There's a number of different poster sessions this week talking about psychedelic-assisted therapy. And so there may be practice-changing paradigms coming on the horizon, but they're not quite there yet for us regular folks in our outpatient or inpatient palliative care units. So finally, what does that mean? Managing depression at the end of life can be challenging. It's difficult to distinguish grief and depression and existential distress and choosing the correct patients. We should work together as a team to identify the patients who would best be targets of an intervention, whether it's pharmacologic or non-pharmacologic. When we can, we should try and address the comorbid symptoms with the medications that we have. And our current antidepressants options are less than ideal, at least for our patients. But we could potentially use a stimulant to augment the treatment of depression at the end of life. And if you're using ketamine for pain anyway, maybe you're also going to get a beneficial effect. And things are going to change in the next 10 or 15 years. That's all I got.
Thank you very much. So we have 3 minutes for questions. I have one in the in the Q&A on the app. So if you would please write those also if you have more. So just also as a comment for Canada, it's available as a special access program, Magic Mushroom currently. So for clinicians, it's possible without but it's more complicated, but it's available to have a special access program.
That's neat.
Yes,
Yeah.
yes, we have done at my hospital. We have done 3 patients without randomized control trials. So
That's awesome.
that's interesting.
That's awesome.
So, what about using mirtazapine 7.5 for appetite stimulant in this context?
So I think the data on that's conflicting. We know 15 or 30 will both be helpful for weight gain and depression. I think what we saw with regular antidepressant sort of non-palliative care patient trials was that as you move the dose higher, we saw more weight gain. It's not necessarily healthy weight gain, it's fat. It's not the lean muscle mass that our cancer patients want, but it could be that at the higher doses where things are more activating, you're more likely to eat. And at the same time, if you have someone who you're worried about mirtazapine and tolerability, and you're starting at 7.5, which may be more sedating than the higher doses anyway, it's still reasonable to trial. It's still a reasonable medication. I would, as long as the patient's kind of relatively robust, I would probably try 15, but 7.5 is a reasonable dose as well.
Thank you. So in late stages of disease, specifically in a hospice patient, demoralized and depressed with caregivers are also becoming demoralized or depressed. So any antidepressant recommended?
For the caregivers?
Yes.
Well, I know, right? What is it? Vitamin K, Klonopin? No, it's hard. And so engaging with your chaplains, right, and trying to find meaning and addressing any sort of psychosomatic symptoms that you can and doing your best is just as important as doing something, right? If patients respond when they know that you're trying and they feel heard, caregivers will respond to that too. And sometimes what we do sometimes sucks, right? It sucks to see patients suffer, and we try our best. If we're able to brighten mood with stimulants, go for it. If your hospice has ketamine available and you're using it for pain, and you know it's reasonable to use, but it's not. There's no magic bullet just yet, and this can really be difficult. And that's part of our job, is to sit with some of the sadness and the grief.
Okay, our last question would be, what is the evidence for oral ketamine in depression?
I didn't find any. So it's all IV infusion. If anyone is aware of oral ketamine for depression, I'd love to see it. But I think all the Cochrane reviews were primarily looking at IV ketamine infusion.
Yes, I've done a lit review on this, and it's only case series. There's no RCT in oral ketamine. So it's sometimes used for anxiety and depression, but it's no magic bullet again. So thank you very much to you both. Thank you very, very much. So now is the time for lunch, and then we'll be back here at 2 o'clock for the next pharmacotherapy session. Thank you very much.